Hello everyone, we're going to be discussing now about demyelinating disorders, and this is part of the neurological section of first aid for Step 2 CK, but it should be good for anybody's clinical knowledge coming to the end of their medical school years. We're going to be talking about multiple sclerosis and Guillain-Barré syndrome. There are other demyelinating disorders. Some of them are discussed elsewhere, such as progressive multifocal leukoencephalopathy, such as acute disseminated encephalomyelitis. But in this specific chapter, we're going to be focusing just on MS and Guillain-Barré. So we'll start off with MS. MS is a demyelinating disorder of the CNS, so of the spinal cord and the brain. And we don't really know what the cause is. It's an unclear etiology, but it is thought to be immune mediated, and for anybody sitting Step 1, it is known to be a type 4 hypersensitivity, so involving your CD4 and CD8 cells. The male to female ratio is 2:1, so it is more common in women, and it's typically diagnosed between the ages of 20 and 40 years old. So in questions, do expect to have a female between 20 and 40 years old. It's usually in that demographic. MS becomes more common with increasing distance from the equator during childhood and in patients with a history of other autoimmune diseases. And MS has been associated with the specific HLA-DRB1 locus, and you can check out which other diseases are associated with the HLA-DR mutations. Subtypes that we have for MS are the relapsing remitting, which is by far the most common. We do also have the progressive, primary progressive, secondary progressive, and progressive relapsing types. I'm going to very sort of briefly just explain what those mean. So in terms of the relapsing remitting, I'm going to draw spikes just sort of showing some form of relapse, okay? So relapsing remitting, the patient's going to be fine, then they have some symptoms, and then they're going to remit. They may remit completely, or it may only be partially, okay? And this sort of disease will kind of continue this sort of trajectory. And over time, the symptoms will get worse and worse and worse. This is being that the x-axis is severity of symptoms. So as you can see, it's relapsing and remitting. In between the sort of relapses, we don't have any periods of progression, okay? They are completely normal, or they haven't got any more signs and symptoms in those periods of remittance. In terms of primary progressive, this has got no sort of relapsing episodes. It's just going to be like a linear line, okay? The patients will just be getting worse and worse and worse. Symptoms will gradually get worse, but they're not going to have any periods where it gets better, for example, okay? It's just going to be progressive fully. Secondary progressive is where it starts off relapsing remitting, and then maybe after one relapse, it then starts to become primary progressive-like, and that's called secondary progressive, okay? And then finally, the last one, I forgot which one I didn't cover. We covered the progressive relapsing. So that's sort of a mix between the relapse and the progressive. So we start off getting worse, and then we have little episodes of sort of severe symptoms in between, okay? Like this. So as you can see, even in the periods between like exacerbations, it's progressively getting worse. We don't have any like asymptomatic periods in between, okay? So they're the four different types of clinical presentation we can have in MS. Looking now at the physical examination in the history of the patient, multiple neurological complaints that are separate in time and space. And this is a really important, this is a really important kind of component to MS, and they're not explained by a single lesion. As the disease progresses, permanent deficits accumulate, as we've seen in the different presentations. Some of the really common things to look out for in MS is eye symptoms. Eye symptoms are almost seen in most USMLE questions for sure. And one of the favourites they like is the INO, the internuclear ophthalmoplegia, which is due to a lesion or demyelination in the medial longitudinal fasciculus. Okay, and in MS they quite often have bilateral. And if you have a woman in her 30s, for example, who has bilateral MLF lesions, i.e. bilateral INO, I would suspect MS until you can prove otherwise, for example. Just in case people have forgotten from step 1 what the sort of INO is, I'm going to very briefly describe it. So if you remember your medial rectus and lateral rectus pathways, so say this is an eye, and then this is another eye. We have the medial rectus here, and then the lateral rectus here. Okay, so that's just to kind of make sure you know what is going on here. We have 2 different nuclei that are important to discuss. We have the cranial nerve 3, okay, nuclei, which would be here, and then we have the cranial nerve 6, the abducens cranial nerve. The abducens cranial nerve is going to be doing input to the lateral rectuses, and your cranial nerve 3 is going to be doing input to the medial rectuses, all ipsilaterally. But there is a connection between cranial nerve 6 to the nuclei of cranial nerve 3, and this is called the MLF, the medial longitudinal fasciculus. And as you're probably aware, we do also have another nuclei called the PPRF, which has input into cranial nerve 6, but that's not so important to understand the concept. So if we lose the MLF, this means if I want to have a gaze to the left, so if I want to have a gaze in this direction, the PPRF on both sides will trigger cranial nerve, the nuclei of cranial nerve 6 to activate the lateral rectus on the left side and the medial rectus on the right side to then do a coordinated movement left. Okay? If I have lost my MLF on both bilaterally, that means I will be able to look left on the left side, but I won't be able to look left on my right eye. So I ask the patient to turn their eyes to the left. The right eye won't be able to move that direction. Then if I ask the patient to move to gaze their eyes to the right, this will require the PPRFs to have input into cranial nerve 6. That will then trigger cranial nerve 6 to control the lateral rectus on the right side to look over to the right, which it can do because it doesn't involve the MLF. But I won't be able to do the MLF's input to cranial nerve 3 to then turn the left eye to the right. So in theory, I ask the patient to look to the left eye can do that, the right eye cannot. I ask the patient to turn to the right, to turn their eyes to the right, the right eye can do that, the left eye cannot, okay? And that's what you'd be expecting in a bilateral INO. Some other signs and symptoms that we can see is limb weakness, gait unsteady, so like some ataxic signs, paresthesia, Lemaitre sign, and Lemaitre sign is an electric shock-like sensation running down the spine and the limbs. It's almost a sciatic-like pain. Blurry vision. This blurry vision can be associated with optic neuritis. This is also very common in MS. This is a painful blurring of the vision, whereas an retinal artery occlusion would be a painless vision loss in one eye. Patients may also have vertigo, nystagmus, urinary retention, and sexual and bowel dysfunction is very common as well. Depression, cognitive impairment can also be seen as well. And very classically, the symptoms worsen with hot showers, okay? And I've had a look at the research. There's no very clear mechanism behind this, but one pathophysiology that tends to be accepted by a lot of people is the idea that myelin is protective for the nerves. It kind of insulates them from hot temperature. So if somebody has a very hot shower, a lot of the nerves that have been demyelinated might actually be harmed by that hot temperature. That's something that I've read. Attacks are very unpredictable, but on average they occur every 1.5 years, just as like a ballpark. And neurological symptoms can come and go or can be progressive, as I've mentioned already. But the relapsing and remitting one has the best prognosis, and it is the most common one as well. One thing just to kind of note, you might be thinking, why is there so many eye problems with MS? And the reason is because the eyes really require fast coordination of movement. I've just explained the pathway of the INO and the MLF. And as you can see, I need to be able to coordinate my eyes in order to move in synchro, right? To move together. So because I need really fast impulses for this, they need to be myelinated, yeah? Myelinated axons are quicker axons. So they're heavily myelinated. So that's why the optic nerve can be damaged in optic neuritis, and the MLF can be damaged in internuclear ophthalmoplegia. Okay, just a quick key fact. Pregnancy may be associated with a decrease in MS symptoms, but this comes at an increased risk when the patient is postpartum. Okay, so it's almost like some rebound that a patient can have of their MS symptoms after they've had the baby. So let's move now on to our diagnosis. Of course, a thorough history is really important. Why is a thorough history really important? Because I need to get the idea that this is relapsing and remitting, most commonly, okay? I need to get the idea that these lesions, these signs, are separated in time. That's why a history is really important. In terms of my two best tests, I'm looking at my MRI and my lumbar puncture, okay? The MRI is the best though. So MRI is the diagnostic choice of test for MS, okay? And it should be showing multiple asymmetric lesions, and the most common one is the periventricular lesions, okay? So just around the lateral ventricles to see demyelination plaques, okay? And these are also referred to as Dawson fingers. I would heavily recommend looking at pictures of the periventricular plaques because they're very commonly shown in USMLE questions, and I'm sure they're going to be very commonly asked by neurologists on your rotations. Active lesions are also enhanced with the gadolinium, but I don't think this is very commonly done in clinics anymore. One very pathognomic finding is when you do your lumbar puncture. So you can check the CSF, and the CSF shows an increase in the IgG index, or at least 2 oligoclonal bands, which are sort of measurements of inflammation. But these oligoclonal bands are only found in the CSF, and not in the serum. But this is usually the findings you see in the CSF. In terms of when to do a lumbar puncture is only indicated for atypical cases where the diagnosis is unclear clinically by MRI. Okay, so maybe the patient has MS, you're not 100% sure from their history, you do an MRI, it's not 100% clear, you can then do a lumbar puncture to confirm or rule out the diagnosis. So, moving now on to treatment. We look at treatments in 2 different schools of thought. We need to look at the acute exacerbation treatment, and then like your sort of day-to-day monitoring of the disease, keeping that patient in remission. So an acute exacerbation, I'm going to be giving the patient a high dose of IV corticosteroids. Usually, methylprednisolone is given. I know for certain in the UK and in most parts of Europe they give methylprednisolone, but that may vary. And you can also try and give a plasma exchange in patients who do not respond to those steroids. That's just going to be removing those inflammatory factors that are causing the MS exacerbation. Now moving on to your disease-modifying medications, we look at 2 specific types. We look at natalizumab and ocrelizumab. These are 2 monoclonal antibodies, and these are usually reserved for patients who haven't responded to other therapies. A big USMLE favourite is the risk of progressive multifocal leukoencephalopathy with natalizumab. Okay, that's your junky cerebrum virus, usually seen in AIDS patients, but it can also be seen in patients who take natalizumab, and the USMLE loves to ask this. Patients with less active disease would not be started on natalizumab or ocrelizumab. They should be started on oral medications, and we can use dimethyl fumarate or fingolimod. Okay, beta interferon therapy and glatiramer have got the highest safety profiles, but they're not so effective. Most patients that you meet with MS are going to be on interferon and glatiramer because they're very safe. But if somebody has got a very progressive type of MS or has many relapses, usually they're going to need to be stepped up to the disease-modifying agents and maybe even the monoclonal antibodies. Just in terms of some other symptomatic therapies, this is not so important for the boards, but we can give things like baclofen if the patient has spasticity. If somebody's got urinary retention, of course, I can give things like cholinergics for them. Anticholinergics can be given for patients who have the opposite of retention and have incontinence. So this would be some maybe oxybutynin. Carbamazepine and amitriptyline are used for my painful paresthesia, like that neurogenic pain. And if somebody has clinical depression and is diagnosed with major depressive disorder, for example, I can also give antidepressants. Okay, so it is a very sort of holistic approach and a very multifaceted treatment approach. I would for sure know the treatment of acute exacerbations very well and know some of these disease-modifying medications too. Just on a side note, I presume if any of you have done step 1 already, you'll be very familiar with this, but I just want to explain it now because step 2 still tests on this a lot. Because MS is a demyelinating CNS disorder, you're going to be having upper motor neuron signs, not lower motor neuron signs. So if somebody has a weakness, expect hyperreflexia and a positive Babinski sign in those patients, okay? If you see a patient who has positive Babinski hyperreflexia but then also has fasciculations, which is a sign of a lower motor neuron, you need to consider another disorder, okay? Right, we're going to move now on to Guillain-Barré syndrome. So Guillain-Barré syndrome is a rapidly progressive demyelinating autoimmune disorder, and it is acute, and it's a disorder of peripheral nerves and cranial nerves. So this, unlike MS, is a lower motor neuron disorder. Very high yield to note, it is associated with a recent Campylobacter jejuni infection, but it can also be seen with viral infections and influenza vaccines as well, but this is very rare. There are also some cases of people who have had COVID, and after COVID, they ended up getting Guillain-Barré after. That's not the COVID vaccine, that's COVID infection itself. This preceding infection triggers an autoimmune response against myelin or the axon of the peripheral nerves. This is an example of molecular mimicry. So the antigens on, for example, Campylobacter jejuni are similar to that of the antigens and the proteins in myelin. So there's a bit of a mimicry and an autoimmune will develop. Approximately 85% of patients make a complete or near complete recovery, but it can take up to 1 year. And their most common type is called autoinflammatory demyelinating polyneuropathy. This is the most common kind of form of Guillain-Barré that you're going to read about in questions and in clinics. There is another type called Miller-Fisher syndrome, and this is a type of Guillain-Barré, and it's characterized by ophthalmoplegia, ataxia, and absent reflexes. And the way I always kind of remember this is by 3 A's. So A. Okay, ophthalmoplegia. I know it begins with an O, but it's got a very prominent A in it. So it's like ophthalmoplegia, and then ataxia and absent reflexes. So just think of those A's and it should come to you, that triad of disorder. So just a quick mnemonic to talk about the sort of presenting complaints and the history that a patient is most likely to have. Acute inflammatory demyelinating polyradiculopathy, that's what Guillain-Barré is. An ascending paralysis, an autonomic neuropathy, and then the CSF finding of albuminocytic cytologic dissociation, which we'll talk about in a minute. So what's the history and physical examination? So classically presents with progressive, and when we say progressive we mean still acute, it's hours to days, symmetric ascending paralysis, distal to proximal, and areflexia. So the patient's going to lose the reflexes and it's going to be an ascending paralysis. Paralysis can progress and involve the trunk, the diaphragm, and also cranial nerves as well. 25% of patients experience respiratory failure and may require intubation. And this fact here is something that the board exams are going to test you a lot on. Autonomic and sensory nerves may also be affected, and this usually leads to a glove and stocking distribution of paresthesia and autonomic dysregulation. Such autonomic dysregulation can be orthostatic hypotension, bladder dysfunction, arrhythmias, etc. And there is also a risk of hyponatremia as well. Just to kind of go over a few of those concepts. So usually, let's just paint a picture. A patient, recent GI infection, maybe had bloody diarrhea. Apologies. Maybe had bloody diarrhea, indicating the Campylobacter jejuni infection. And then a couple of weeks after ends up having tingling, paresthesia, numbness in the feet, and then followed by weakness in the legs, ascending up to the knee. They will have no reflexes, and then maybe after a couple of days, they're going to start to have maybe some weakness in the arms, maybe some orthostatic hypotension, and maybe some bladder problems, and then eventually they may start to get shortness of breath. This is usually how the picture is going to be painted in Guillain-Barré. In terms of the risk for hyponatremia, there is no specific well-identified cause of this, but it's presumed to be related to syndrome of inappropriate ADH secretion, my SIADH disorder. There is a couple of other people that suggest it due to dysphagia problems in patients with Guillain-Barré. They're not able to consume enough food with salt in, but there's no common consensus on that, so that's a bit of a question mark in medicine. So how do we diagnose Guillain-Barré syndrome? We need evidence of diffuse demyelination. That's essentially what we're going to be requiring in this diagnosis. And how do we sort of find evidence of that? We need to do nerve conduction studies. Okay, so we're going to do a nerve conduction study, and you're going to see a decrease in nerve conduction velocity. Okay, we'll talk about this when we talk about some other disorders in later chapters, how we can differentiate disorders based on EMGs and nerve conduction velocity studies. We can also support this diagnosis by doing a lumbar puncture. Okay, and this lumbar puncture will find an elevation in CSF proteins above 55, but yet my white blood cell count is normal. And this is something called albuminocytologic dissociation. That means that my proteins are going up, my albumin's going up, but my cells, are not going up as much. So there's a dissociation between the two. And this is pathognomic for Guillain-Barré. Just a quick key fact, remember that ascending paralysis with normal CSF findings and without autonomic dysfunction, i.e. in brackets, this is not Guillain-Barré syndrome, is characteristic instead of tick-borne paralysis. Tick-borne paralysis is not commonly tested in USMLE, but it's usually due to the dermacentaur tick, and the ticks that are very commonly associated with Lyme's disease as well. And this causes some immune reaction that ends up causing things like ataxia, paralysis. Again, it's not very common, but if you do see a patient with ascending paralysis and the CSF is completely normal, you can add tick-borne paralysis in your differential because it's unlikely GBS. And finally, last but not least, we'll discuss treatment. So, frequent monitoring of the maximal negative inspiratory force and vital capacity are vital. Why? Because we need to know whether this patient is at risk of impending respiratory failure. Patients who have a decrease in either one of these values should be admitted to ICU and they need to be ventilated. Okay, this is a huge SOS for the boards and also in clinic as well, but USMLE loves to kind of ask on this concept. In terms of actual treatment, plasmapheresis and IV immunoglobulin is first line. The IV immunoglobulin that we give is a pooled IV immunoglobulin, i.e. we take immunoglobulin from many different patients, and it's one of the very few disorders that actually uses pooled IV immunoglobulin. And an important thing to note is that corticosteroids are not indicated for this, like they are with MS. And then afterwards we need to be doing physical rehabilitation as well, because these patients are going to have weakness that can last for a very long period of time. If the patient had, for example, problems with their respiratory muscles, they will also need therapy for that as well. And that draws to the end of the demyelinating disorders. I hope it was helpful.